Really wasn't my life's ambition to be here for that reason, but there we go, life brings the unexpected. But I am delighted to be here with you because actually, yeah, if somebody can put that in the right place for me, you are a rare and unique and important resource, and you have immense responsibility for the care of people like me. I want to talk to you about the, thank you. I want to talk to you about the impact of having chronic norovirus alongside other diagnoses, so I sort of fit the bill that's just been described, and the care that goes with all of that. But before I do, we're being seduced by Emma here. Does anybody know of the character Emma Peel? You have to be of a certain age. Here she is. She is the heroine of a British TV series called The Avengers, and I hasten to add that this is not my self-characterization, but was given to me by the chair of an NHS organisation that I used to work for. And when I would come into a meeting, he would say, it's Emma Peel, the Emma Peel of speech and language therapy, which I kind of think probably says more about him than it does about me. But here's the reality check. So this is me at that time in my 30s, and I think probably brown hair and black trousers is the closest that the resemblance gets. So let me tell you about the real me. In my spare time, in my 30s, I used to train alongside the UK gladiators. So I was very fit, which may have led somewhat to the stereotype. And like you, I was passionate about my work and about making a difference for the people who used my services. I was known perhaps for being a little bit feisty, and that may still be the case, but also I'm told for being entrepreneurial, improving services, having energy, and getting things done. And of course, I had CVID. Actually, conveniently, I'm so short, I can't see the time down there. So if somebody wants to wave at me when, thank you. I had the usual experience of frequent and enduring infections, some autoimmune problems, but although it wasn't easy, I generally managed health alongside life, using strategies like carefully pacing myself, always setting deadlines and keeping to time, setting deadlines well before they were due, just in case I got sick. And because I always met deadlines, I occasionally skipped off to have some fun and the odd adventure, and found myself appearing in a Michael Caine film, a very bad one, I hasten to add, but there we go. Somewhere else I didn't expect to find myself. Life was challenging, but it was varied and it was fun. Here's a coaster given to me on my last birthday. Now, in my part of the world, Crazy Cat Lady is a rather sad individual who invests most of her emotional and intellectual energy into cats. At age 50, I'd opted to take early retirement, working part-time when I was able to, and volunteering once a week at Battersea Cats and Dogs Centre. It is a great place, but it really wasn't where I expected to find myself. And I was volunteering in order to try to rebuild some connection with the outside world. So what had happened? Well, when I was 48, the complicated picture that we've heard described had set in. Spleen, liver, skin, all went a bit wonky, and the diarrhea that I'd had since a teenager became very severe. And this chart shows the growth in number of my diagnoses over a 6-year period, with a further diagnosis of chronic norovirus in 2014. Now, I will talk briefly about my treatment, but I'm a patient, and as you know, and as we've just heard, actually it's a very complicated picture. So on your pen drives, you will find a document that contains all the details of tests, diagnoses, and outcomes of treatments, as well as contact details if you want to network, which I think is a critical outcome of an event like this, to actually see the local protocol that was used in the treatment of my norovirus. And I'm very grateful to my clinical immunologist for giving endless time actually in pulling that detail together into that document. The impact of my symptoms was that I actually slipped from resilience into what I would say is a state of helplessness and actually I would say despair. And as my symptoms got worse, I experienced considerable nausea, a soul-shredding fatigue, loss of appetite and of concentration. I generally only got 2 to 3 hours of sleep per night for a period of at least 6 months. The only way I could safely leave the house was by not eating at all until my return, and I had to turn down job opportunities because these were based on a level of performance and a reputation that I knew I could no longer live up to. My relationships with friends fell away because I wasn't able to join in activities. I had less to contribute. I had less to say because I wasn't getting out. And my friendships had become skewed around providing help. So, for example, becoming the escorts that the hospital demanded for endless endoscopies and biopsies. And yet, I was so much luckier than some, and I know that you are coming from parts of the world where patients have not got access to the excellent clinical team. I'd now been under clinical immunology team for 8 years and receiving regular IVIG. I also had access to all of these specialisms, to all of whom I was referred. However, the stress of what became multiple, fragmented pathways actually added to the impact of my symptoms. So, for example, when I was referred to a specialism who actually already knew me because I'd been knocking around for a few years, I would often see someone with no knowledge of my case. Some diagnoses seem to be made without any interpretation of the context of my symptoms within primary immunodeficiency. And this is just some of the news that came thick and fast. Now, it won't surprise you, because you've been talking about it all morning. Now, whilst I recognise that these are all relevant hypotheses in the context of CVID, it was actually a bit tough to take this all on the chin when it then took months to put them into a context of what they meant for me. This, together with feeling physically very poorly, spending a lot of time at hospital, began to affect my decisions and my hopes for the future. Would you buy that house? Would you go traveling? So, looking back, I can't help wondering how much more effective and efficient it would have been if my clinical immunologist had actually spoken to those other specialisms first, perhaps agreed together what diagnostics were needed and just set them in place. I would also have found it so much easier for those specialists to discuss the findings together, or ideally with me, rather than me carry the information back and forth between them. And looking back, don't we promote to prospective patients and to funders of services that diagnosis and referral to a clinical immunology team stops all of this? So, what did my life now look like? Well, out of one of those 6 years in that chart, I had 34 outpatient appointments, I had 17 days of infusions, and I had a 2-week admission. The circumstances of that admission were that my had become even more severe. I'd lost 19 kilograms over 3 months. Efforts had been made to access investigation by gastroenterology, but 6 months later I was still waiting. And I was told that my only option was to present at A&E. I don't do that. I go to A&E when I've severed a limb. But anyway, I was given no other option. Considering the diagnostics carried out over that 2-week stay, the fact that at the time of that admission I was caring for my mother who was moving into end-of-life care, and that the outcome of that admission was back to the same symptom management, I was left wondering if that too could have been done differently. In that 1 year, I lost 24% of my total time for living and 39% of my time for working. And yet, what makes my life worth living are my family, my friends, my career. I found those photos, and I found just a few of them. These are just a few of a whole series that looked like this. Now, I don't much like looking at these now. At the time, I thought they were quite good. But this takes me back to how I was feeling at the time, which was disconnected from friends, from community, from life, and ironically, considering the number of appointments I had, disengaged from those delivering my healthcare. At this point, I had given up, and I felt that I'd been left to cope completely alone. However, there was a turning point. I wouldn't leave you there. The priority was now my chronic norovirus. And 1 minute. Okay, I may leave you there. And I was actually allocated a consistent named clinical immunologist. And this clinician went out of their way not only to talk to other clinical immunologists about what they were finding in similar cases and actually draw down not only on the hard evidence of which there was very little, but the informal developing consensus. And I think that that's why the networking here is critical. But also, this clinical immunologist talked to the other specialisms and negotiated my management across the pathway. Sometimes this was formal, in, for example, joint clinics. At other times it was informal, but it resulted in streamlining of what had been endless diagnostics and outpatient reviews. What also made a difference to me was a style of what I will call confident humility. Now, for me, this is the critical patient-centered bit. When we are trying a treatment for which there may be little definitive evidence and which may or may not work due to the differences between one person with CVID and another, when I'm being asked to take another step into the unknown, it makes all the difference to know that treatment will not only be shaped by formal and informal evidence, but also negotiated, coordinated, and systematically followed up in terms of its impact on both my health and my life. Details of my treatment are in that document. Briefly to say, I am currently taking ribavirin with a low-dose steroid, and we can't actually say that I've cleared the virus, but you need not worry. The virus is suppressed, so you're safe, in that it only appears occasionally now and at very, very low levels. Now, that is a treatment that's produced some outcome for me, and we arrived at that after other 2 treatment regimes which didn't work for me, but have done for others in my service who have chronic norovirus. So there's the complexity that was being described. I do want to say that actually what struck me, though, was that even before we reached a point where the virus was suppressed and my symptoms reduced, once the burden of uncoordinated care was lifted from me, I actually found that I could use my resources to rest and start to recover. There is nothing worse than feeling the way that I did and having to go back and forth to those 34 outpatient appointments. I could also follow through my own commitment to make more effort to eat, which had become really, really, really difficult. And I could make that commitment because I could now see that there was a plan with direction. And gradually, as my symptoms slowly decreased, I began to feel so much better. But I do have to say that there remains a lot for me to rebuild, and a legacy of much that is permanently lost in my life. So, what I've learned is that it's critical for me that the clinician alongside me in the clinic is willing to look up from the test results and see the system from my perspective, is just as passionate about the model of care as these other three dimensions, and is willing to step up and change the way we do things around here. Now, why do I say that bit? Because over the course of those 6 years, what stood out for me is whenever I raised polite, I've got less polite of late actually, whenever I raised polite queries about whether things could be done differently, everyone said, oh, I know, it shouldn't be like that, but, and actually everybody attributed what was wrong to the system, and somebody called they was responsible for this. Now, a message I want to give to you is the next time you find yourself saying to a patient, I know it should be different, but will you stop and think about this, please? And just think, what one thing can I do, even if it's just one small step? Your patients need you to lead, not just on treatment, not just on research, but also on the model of care, because you are the only ones in a position to hear, if you ask, about the impact of the whole pathway on our well-being. Final slide. I think this slide has a message for both me and for you, and it's the thought I'm going to leave you with. As you go forward to have a very good congress branded as putting the patient's interests at the centre. Thank you for your important long-term work to make a difference in the field of primary immunodeficiency. And thank you also for every action you take to improve the experience of the patient in front of you. I think this is something that you very much, a role you need to promote, and to promote with evidence if you are going to safeguard our services. So tweet me with your thoughts, but in the meantime, thank you for listening.